Welcome to Endometriosis Voices, listening to lived experiences, learning from science. I am Isaac Chebafo. In today's episode, we are going to discuss why surgery, though valuable endometriosis management procedure, is not a cure for endometriosis. We are going to look at what the evidence say about the strengths and weaknesses of surgery as a management tool for endometriosis and how it can be triaged to the needs and circumstances of the individual suffering from endometriosis. On one hand, we know that surgery can be life-changing for many suffering from endometriosis, but on the other, we are also aware that symptoms and lesions can come back even after a very successful surgical procedure. There are currently two surgical procedures that are used for endometriosis management. First, one of them is excision. In this procedure, visible endometriotic lesions are cut out to remove the entire depth and borders of the lesion. The second is ablation, which is where the surface of lesions are destroyed, often by burning with heat, laser, or other forms of energy. However, this particular option does not necessarily destroy the entire nodules of the lesion, and recurrence rate is very high in this option. How effective surgery is to pain relief and disease recurrence is closely linked to whether or not the whole lesion is fully removed during surgery, primarily because surgical procedures do not really target the biology that underlies the occurrence of endometriosis lesions. Look at it this way. There is a burst pipe that is causing a leakage, and when it leaks for a long time, it floods your room. Surgery puts a very big basin under where the leak is coming from and do not necessarily fix the leak itself. How long you remain safe from the occurrence of another flood in your room is largely dependent on the size of the basin that is put under the leakage. That said, randomized and comparative studies show that both excision and ablation significantly reduce endometriosis-related pain for about 6 to 12 months compared with no treatment. In one clinical trial, researchers reported a significant improvement in chronic pelvic pain score when the lesions are cut out compared to when they are burned. Other studies have also reported a 70 to 80% of patients have a clinically meaningful reduction in pain after laparoscopic surgery, especially when excision is the main technique. And for a substantial proportion of these individuals, pain relief can last for several years. In ovarian endometrioma, which is endometriosis in the ovaries, excision has been shown to offer better pain relief and reduce disease recurrence compared to drainage and ablation. So if we are connecting the dots together, then at this point we know that the complexity of your endometriotic lesion, the type of lesion that you have, as to whether or not it is a deep infiltration, superficial, or ovarian endometrioma, and the expertise and experience of the surgeon are critical components that come together to determine whether or not your surgical procedure will successfully or effectively relieve pain and prevent or delay disease recurrence. Ablation almost always underperforms excision for long-term pain relief benefit and prevention of disease recurrence, especially at the site of the surgical procedure. This is because in many lesions, especially the deeply infiltration ones and endometrioma, what is visible on the surface can be likened to just a tip of the iceberg. Deeper infiltration cells may remain when the surface is just burnt. Surrounding fibrosis and nerve fibers, which are the information highway for pain transmission to the brain for interpretation, and blood vessels that are deeply buried into the deep tissues may be untouched. In addition, thermal spread may scar tissues without fully removing the entire disease. And so it is not uncommon for disease recurrence to be seen at the same site where the superficial ablation was performed. Thus, ablation may be reasonable for very shallow implants in safer locations, especially when used with other treatment options. So at this point, you would reason with me that it is not an issue that ablation is always wrong. It is when ablation is used alone for deep nodules, endometriomas, or complex disease that is better suited for excision. There are some circumstances where ablation is completely not recommended as a surgical procedure for endometriosis management. Classical example is deeply infiltration endometriosis that are affecting the bowel, the bladder, the rectovaginal spectrum, which is the area behind just the vagina wall and the rectum. Global endometriosis management guidelines and expert reviews place significant emphasis on excising the nodules in these cases as a standard approach and tailor it to the depth and circumference of the involving tissues. This is largely because surface ablation on the bowel may briefly reduce visible disease, but usually leave most of the infiltration lesions in place. On the other hand, if excision is done and done properly in these areas, it can significantly reduce pain, prevent disease recurrence, especially at the same location, and significantly reduce the need or possibility of repeat surgical procedures in the future. In most of these cases, an advanced and often multidisciplinary team may be required to be able to successfully remove the endometriotic lesions without significantly affecting the organ function. And so, for instance, a gastroenterologist may need to be consulted to advise on the depth of excision and how the tissue repair is supposed to be done to ensure that the digestive system function is not affected. At this point, the surgeon's honesty about their own learning curves and building a network for referral is very important. For the endometriosis sufferer, it means it's rational to ask, how often do you do this type of surgery? And do you work with multidisciplinary team? This is a perfectly reasonable and harmless question to ask if your diagnosis come out that it is deeply infiltration endometriosis that is affecting, for instance, the bowel, the ureter, or the rectovaginal septum, or if you have a very complex disease. Think of someone with a 3 cm rectal deeply infiltration endometriosis nodule and a severe pain. In this circumstance, a superficial ablation may offer some pain relief in the next few cycles, but also likely leave more of the disease. A planned excisional surgery with colorectal input might also mean a very longer initial recovery, but a much better chance of sustained relief and possibly prevention of disease recurrence, at least not at the same site where the excision was performed. This is the kind of nuances that needs to be discussed and also get involved someone who has been performing a colorectal surgery to offer counsel or be the one performing the procedure to ensure that the entire lesion is completely removed without necessarily affecting the physiology of the colon. There are a number of reasons why surgery is not a cure regardless of how effective it becomes. Why some endometriosis sufferers can benefit from long-term pain relief and or without disease recurrence at all. But first, let's look at the disease biology. Even though we currently do not understand how exactly endometriosis occurs, various biological processes have been espoused to explain how it possibly could occur. One of which is retrograde menstruation, which is where menstrual blood flows back into the pelvic cavity through the uterine tubes. Regardless of how effective your surgery is, if this particular biological process turns out to be the actual way endometriosis occurs, surgically removing the endometriotic lesions does not fix the retrograde menstruation. For surgeons, honest counseling is key. Let your patients know that the surgery can offer some pain relief without necessarily promising them the possibility that the disease may never reoccur. Develop a comprehensive post-surgical follow-up plans and robust complementary treatment options that involve the participation of your patients in the planning stage. Ask for help in areas where your expertise does not reach. For instance, performing surgical procedure for the excision of an endometriosis nodule that is affecting other organs that you have no expertise operating on. To conclude this episode, the success of surgical procedure as a management of endometriosis is not measured on whether or not the disease reoccurs sometime in the future. Rather, whether there was an improvement in pain relief and how long that pain relief lasts. Did the procedure minimize and protect fertility where that mattered? And was there a conscious integration of long-term medical and supportive care in addition to the surgical procedure? Excision and ablation are not competing religions. They are tools. However, excision offers far better pain relief and delays disease recurrence compared to ablation, especially for deeply infiltration endometriosis and ovarian endometrioma. Thank you for spending time here and for taking your health seriously. If you find what we do here important, share it with someone you think can benefit from the page and its content. Endometriosis Voices, listening to lived experiences, learning from science.